Hello everyone, and I hope everybody is doing perfectly fine. So today I'll be discussing approach to a rare case, and the diagnosis made was bilateral xanthogranulomatous salpingo-ophoritis, and this will be discussing in a patient with Mullerian anomaly. So this xanthogranulomatous salpingo-ophoritis, it is a very rare chronic inflammatory condition, and kidney and gallbladder are the usual organs which gets involved. And this entity, its involvement in female genital tract is very rarely seen. And the diagnosis, actually it is very difficult to make this diagnosis just on the basis of your clinical and radiological findings. So it has a variable presentation. So because of which is a local destructive nature hai, mass formation, which leads to what it does. It gets enlarged, it forms a mass, and what it does, it destroys the adjacent tissue, nearby tissue, and mass formation or destructive nature ki wajah se what happens? It leads to fibrosis and adhesion, and that's the reason it can mimic malignancy also. So here comes the role of our his detailed histopathological evaluation. What we'll see here, sheets of foamy macrophages in ovarian as well as fallopian tube parenchyma. And in literature, what we found is very handful cases of xanthogranulomatous salpingo-ophoritis have been mentioned. And in our case, they become much rarer in the fact that this entity, it mimics malignancy, and it was found in bilateral ovary and bilateral fallopian tubes in a patient with Mullerian anomaly. So basically three rare findings what we got was it was involving both ovaries, both fallopian tubes, it was mimicking malignancy, and third it was found in a patient with Mullerian duct anomaly. And so to our best of knowledge, this is the first case to be reported in literature. So starting with the history. A 37. So now I just see how the case proceeds and what initially we got. I just gave you an initial insight into the topic of what this entity is. So a 37-year-old female, she presented to her hospital with chief complaints of pain abdomen for last 2 months, and she was a known case of primary amenorrhea with Mullerian agenesis. And on ultrasound, bilateral tubo-ovarian mass was detected and with hypoplastic uterus. So following the relevant clinical and radiological details which we had, and the patient was subjected for subtotal hysterectomy with excision of her bilateral tubo-ovarian mass. So this was the mass which we received. So you can see bilateral, both the sides of ovary. This is the cut section. Cut section you can see. This is the external picture, the mass, and this was a cut section. I'll show in detail. So, and this was the cut section from the uterus, the hypoplastic uterus, which we got a globular, small globular in shape was found. And then we cut the section, and then with this cavity was seen, the uterine, this endometrial cavity was noted this much. There was no cervix in it. So it's a hypoplastic uterus. So here the cut section of fallopian tube, dilated fallopian tube, you can see here cut section of it which was attached to the uterus, and this is a separately sent another fallopian tube. So we gave multiple sections, we gave detailed sections from our from her right and left tubovarian mass, and also we gave from the this left right tubovarian mass as well as the uterus and the adjacent things which was sent for the gross. So on section what we saw on histology, we saw extensive sheets of histiocytes along with corpus luteum, moderate chronic inflammation and increased vessels. So this we got in the mass. And section from fellow ovarian parenchyma showed the presence of extensive sheets of histiocytes. And fallopian tube also showed extensive sheets of histiocytes, chronic inflammation, congestion in mucosa and submucosa. So see, this is the fallopian tube structure. The plica, you can see the जो अंदर आ रहे हैं ना ऐसे fallopian tube के structures. So in these all, this is the low part. So जितने भी started and these are histiocytes. I'll show you the high part. So see, this is the single cuboidal line called cuboidal to columnar line epithelial surface. और ये जो बीच में है, these are the sheets of histiocytes. One more high part I have just see. So this is the ciliated epithelium. You can see cilia. Then this is the single line cuboidal columnar to cuboidal epithelium with pseudo stratification. And here what we are seeing is This is the whole sheets of your histiocytes. This section was from the ovary. Ovary also we got the same histiocytes, sheets of histiocytes. And these histological finding we got in both the ovaries and both the fallopian tube. So it is bilateral xanthogranulomatous salpingo-ophoritis. And then secondary, the other part, we give sections from other part also. So this sections from endometrium showed endometrial glands with focal crowding. So glands were placed back to back and there was cellular stroma and few glands showed reactive changes. Marked chronic inflammation was noted comprising of lymphoid cells and myometrium showed, endometrium we got this hyperplasia focal formed sections from myometrium. It showed endometrial glands embedded in the muscle layer. So we got endometrial glands in the myometrium. So that suggests adenomyosis. So we applied CD68 marker also. Though the histology was very obvious, but what we did, we applied CD68 in the sheets of histiocytes and it came out to be very beautifully positive in both left and right ovarian mass. This was the section showing your endometrial. So we can see endometrial glands embedded in the myometrium. So this is adenomyosis. Here we are seeing increased endometrial glands was there. So this simple hyperplasia was seen. So basically based on our detailed histological evaluation and immunohistochemistry, a diagnosis of bilateral xanthogranulomatous salpingo-ophoritis was given. No atypical cells were seen in the section examined, and in addition, the sections which we took from endometrium and myometrium, it suggested the presence of simple hyperplasia without atypia and adenomyosis. So many pathology we could get in ovary, fallopian tube, uterus, that is endometrium and myometrium in the patient. So coming to discussions, a few points about this entity. This is an unusual type of chronic inflammation as I already discussed, and here what happened, there is a local destruction of the involved organs by inflammatory cells, which is comprising of a large abundant lipid-laden macrophages, lymphocyte, plasma cells and occasional neutrophil. Usually these xanthogranulomatous lesion हम देखते हैं routinely we see in kidney, gallbladder, urinary bladder, bones, stomach, testis and epididymis. It's quite rare to find this entity in female genital tract and usually it is limited to your endometrium. Fine, only few cases of female genital tract have been reported in India with involvement of xanthogranulomatous inflammation. And जो भी report हुए हैं, कुछ cases हैं जो ovaries में report हुए हैं, and only few cases of xanthogranulomatous ophoritis with fallopian tube involvement have been reported in literature. And one study they had reported 6 cases in different age group. And then what they do, they found that in all these 6 cases were misdiagnosed as malignant, as ovarian neoplasm. So first case of xanthogranulomatous inflammation of serosa of uterus, fallopian tube and ovary was reported as inflammatory pseudotumor of the pelvis दिया गया था इसको entity. It was given in 1976. So involvement of adjacent structure, actually this has, as I said, it has a tendency to spread locally. So what they do is the nearby destruction कराते हैं, so that creates an impression that that lesion is a malignant lesion. So moreover imaging thick walls होते हैं जैसे surrounding में जो grow कर रहा है ये mass, the histiocytic lesion. So it has a thick cystic wall with solid areas in the ovaries. So there is a suspicion of neoplastic etiology on ultrasound or imaging also. Though the exact etiology when we think about why it occurs, xanthogranulomatous ophoritis, so it is not clear yet, but there has been association with leiomyoma, infection, endometriosis, and use of contraceptive devices, inefficient, inappropriate drugs, or abnormalities of lipid metabolism. So infection also has been accepted as a theory which leads to this xanthogranulomatous inflammation, like example are E. coli, bacteroides, fragilis, proteus, salmonella typhi. So xanthogranulomatous ophoritis, it was described as a complication of typhoid. So it has been hypothesized that colonization of this intrauterine contraceptive devices also leads to bacterial shedding in the lumen of fallopian tube. So these few etiologies they have been considered to be an underlying defect in xanthogranulomatous ophoritis, salpingo-ophoritis. So gross हम कैसे दिखेगा हमारा? The affected ovary जो होगी, it will be well circumscribed, solid, yellowish, lobulated mass along with the cystic change. Microscopically, as we saw, sheets of lipid-laden macrophages, and we also call it as xanthoma cells and inflammatory cells, which comprises of lymphocytes, plasma cells, along with few neutrophils. Now coming to the important point, the rarity which we had in our case, जो ये bilateral xanthogranulomatous salpingo-ophoritis है, this was found in our patient, 37-year-old, with Mullerian duct anomaly. So Mullerian duct anomaly, इनका detailed classification, I am not going into the detail. So ASRM जो है American Society of this Mullerian duct, they have a gynecological society. So they have a classification which divides the Mullerian duct into 9 categories. So Mullerian duct anomaly incidence in general population is 0.1 to 3.5%, and usually what you see in 6% cases of Mullerian duct, they have fertility problem. 10 to 16.5, they will have recurrent abortion. What are the most common identified forms of Mullerian duct anomalies are? The patient of Mullerian anomaly can present to you with septate uterus, arcuate uterus, didelphys uterus, unicornuate, and hypoplastic. So our patient presented with hypoplastic uterus. So to conclude, I would say that this by finding this bilateral xanthogranulomatous salpingo-ophoritis in female genital tract, that is very rare, and main thing is it mimic malignancy. So we have to be very thorough and very vigilant before we give a diagnosis. We have to rule out like is there any presence of any malignant cells or not. So after ruling out, properly putting CD68, confirming it to be histiocytic cells, so we can give a diagnosis of this rare entity. And to add to this rarity कि ये दोनों bilateral tubes and ovaries में हो रही थी ये lesion, mimic कर रहा था ये malignancy को. And third rarity was it presented in patient with primary amenorrhea, Mullerian agenesis, and hypoplastic uterus. And this uterus also showed the simple hyperplasia without atypia and adenomyosis. So many pathologies we could detect with a proper, vigilant, detailed histopathological evaluation. So thank you so much. And as also I said कि this exact etiopathogenesis is not known. So हमने variety of factors देखे हैं. So mimicking malignancy. So as I said, detailed comprehensive approach if we apply, detailed clinical, radiological, and immunohistochemistry, everything keeping in mind, and then making a diagnosis. So these are few of my references. Thank you so much for your patient hearing. So kindly like, subscribe, and share my YouTube channel Patho with MK. Thank you so much.